Okay, everyone. So I hope you had a chance to stretch and to get a few more drinks and other things and get ready for our next speaker. We're very fortunate to have Dr. Melissa Simon with us today, who is Vice Chair of Clinical Research in the Department of Obstetrics and Gynecology at Northwestern. She's also the founding director of the Center for Health Equity Transformation and the Chicago Cancer Health Equity Collaborative. Dr. Simon has a number of noted awards that she's won. She's a member of the U.S. Preventive Services Task Force, and I was fortunate to meet her during my 4-year stint on the Dissemination and Implementation Science study section. She chaired that and was very enlightening, runs a really tight meeting and a very tight agenda, and so we are all looking forward to hearing from her today and about her work in Chicago around health equity. Thank you, Melissa.
All right. Thank you so much for having me here. And I'm sorry I'm the barrier between you and lunch, but we're going to make it through. Good morning, good afternoon, everybody. Oh, come on, let's go. All right, good. All right. I have nothing to disclose, but because I'm on the USPSTF, I have to say that my views and my talk does not necessarily reflect those of the USPSTF. And thank you, in case you have to leave early, thank you for being here. It really is an honor, and congratulations to your CTSA. It's amazing. So I'm going to keep this as casual as I can, and I really want to thank Jeffrey for teeing me up and providing such the important substrate and background and knowledge to help me articulate the on-the-ground kind of work, and that's what this talk is about. So what do I mean by lifting everyone's health? And I really do think implementation science is one of the best sciences and approaches actually to actionize, if I may, health equity work and advancing health equity. I think implementation science is really a key driver for that. So let's just take a few minutes to think about this. So what actually creates health? All right, why do I care about the outside of the box thinking? Because most of health is not, as we know it today, is not created by genes and biology. That's about 10%. All right, and about 10% is due to clinical care and about 30% health behaviors, but 50% is social economic factors and physical environment, half. So in order to really think about that, you got to think about all that background and that implementation stuff and all that scaffolding and thinking outside of the box. So it is not about the me, it is about the we. So collectively, a lot of people and a lot of players and a lot of sciences need to gather around and community members and organizations and sectors in order to actually lift the health for everyone. And it's about the and, because we can't just think about the way we do business or the way we've done it or the way we've done research or the way this is the RCT, the gold standard clinical trial type design. We got to think about other ways in order to move the needle in health, other ways of doing things. So thinking outside of the box is really important. I always talk about the secret menu because my husband is from China and we go to Chinese restaurants and there's always that better food that is not on the menu. So if you can't speak Chinese or if you can't read it because the menu, the good stuff is usually on the wall, you're out of luck with ordering real, authentic, and awesome Chinese food. So thinking about what's behind the scenes or the structure or the scaffolding or the policies or the rules that impact down the line, the downstream stuff, right? The output, which then impacts disparities and equity or inequity. So I'm an OB-GYN. I had a baton. Make sure I saw that. I'm going to take it a little differently. Handoff is important, right? So I am a supervising physician, so I teach, right, at Northwestern, and I often do not have my hands on the delivery because I'm helping talk people through it. So I get to sit in the back, stand in the back, and kind of observe the room and the family. And it's one of my favorite things to do because it is a great privilege in my life to be able to experience birth and hand the baby to the family. That's one of the most, I say, wonderful joys in the world these days. And so that's really important to me. But I get to think about, where is this baby going, right? What's the family like? And then I think outside of that 50% other stuff that makes the health, right? So what's the environment that they're going to? What community area? So Chicago is one of the most segregated cities in the country, and that really drives a lot of our health inequities. And so which community area are they going to, or suburb? What's the education system like? What are the job opportunities going to be like? What's the racism like? Segregation, right? Perceived discrimination, all of those things and more impact this baby's future and this baby's health. And so those are the things I think about. And again, it connects directly with what you just heard from Dr. Curran's talk on implementation science. So then we take it a little step further. So architecture and engineering. Design's really important. So we have 4 kids. We have a lot of this around the house. But architecture and design is really, really important. And that's important for implementation science. And includes dissemination, includes de-implementation. So if you think about Architecture 101, form, content, context are really important. And the basic design elements, right? Whether it's texture, space, unity, harmony, balance, hierarchy, scale, and proportion. Those are all things that we have to think about when we either implement something across a health system or work with a community partner or organization or set of organizations to design a new policy or new way of doing things, or even design a randomized controlled trial or a bench experiment. We have to think of all of this, and because that structure and design impacts the output, right? Your research question impacts, and the research question scope and scale of who you involve in that research, or what kind of samples, who you're getting those samples for to bring to your bench, that impacts the impact of who that, or the populations that research will then be applicable to, the generalizability, right? All right, and that design process is iterative, just like implementation science, right? It's iterative. So if you take that a step further and bridge it with health equity type thinking, right? What does it take, and who decides what studies get funded, right? How are the RFAs, requests for proposals, designed that impact how you create your research project? The whole CTSA and also the Cancer Center renewal support grants, right? Those big funders of funds now have community as an important structure of that, right? And that is purposeful and important, because if that wasn't in the RFA, I would dare to say that that community and equity work may not be as showcased as it is today and funded as it is today. Right? So those kinds of things. Who sits at the table when admissions decisions or faculty recruit decisions are made, right? How are those policies formed that then impact millions of people, right? So that's the implementation, design thinking, and that intersects with health equity. So just definitional. So equality doesn't mean equity. So if I were to take all of you on a field trip to an apple orchard, which is apropos right now because your apple orchards are wonderful here in New Jersey at this time of the year. And I told you all that I wanted you to pick an apple. That was our goal. First, obviously, I'd have to convince you to get on the bus or the car or however to get to the orchard. I'd also have to convince you that you want an apple and not a pineapple or cherries or no fruit at all, right? So I have to think about that to get you all together and us all on the same page with what our goal is. But then I have to acknowledge, and we have to acknowledge, that for equity, that the lift to get you to that apple, or the way to get you to that apple, that goal, will be different for each of you. I mean, some of you will all just be able to go like this. All right, but for someone who's more vertically challenged like myself, I may need a little step stool or something, and maybe some help so I don't fall off. And some of us won't be able to necessarily stand and pick the apple, and we might have to help them get it. But that is it. That's the healthcare delivery, and the getting rid of that implicit bias and addressing that implementation science delivery. That's really important. That is an important point, that we have to tailor that box or that lift or that mechanism to get all people to the same goal. So again, the other way of thinking about it is, why are there two different cliffs or multiple different cliffs, right? So why do the orange and yellow people on the upper part of that slide have primary prevention, or the fence that prevents them from falling off of the cliff, or the net in case they do somehow figure out how to get through the fence, or an ambulance that actually works with tires that are inflated and a GPS that works? And why do the green people on the other cliff have pretty much nothing? Or holes in their system, right? Why? So they're huge issues to tackle, and implementation science, as Dr. Cran just set us all up for in a wonderful talk, really just bridges that divide and can help actionize health equity work, I would say, more effectively, and scale it. And so this is just one of those. This is CFR. This is the Consolidated Framework for Implementation Research. It's just one of the many that he talked about, the frameworks. So there's a lot of frameworks. So we're often asked which social determinants to improve. Like, there's a whole bunch, right? And many of our policies and prescriptions and interventions try to help people and circumvent the obstacle, and some of them actually work, but the problem is the sustainability, which is sustainment is another part of implementation science, and that's the part, like, you'll see it in patient navigation as a great example, and I'll talk a little bit about that in a few minutes, but where patient navigators and community health workers are often funded on soft money that can go away really quickly, or philanthropic funds. And sustainment of that, even though we have evidence-based proof that they help, especially for certain populations and in certain circumstances and environments, but sustaining them is another problem, right? And so the answer to the issue is that it requires all of this, right? It's a hot mess what's required to actually lift the health of everyone, and it's a hot mess to try to figure out how to get everybody to reach the apple, or to get an apple if that was the goal, right? So here's just an example, right? I'm not going to solve the world's problems, as was previously said, but what can we do, right? Health equity by design. So design thinking, implementation science, those are all important. So here's Chicago. Chicago, again, there's 77 community areas. On the left is just the population by what race and ethnicity, so white being magenta, Latinx being orange, black being blue, and Asian being green, smack dab in the center of Chicago. And then the community area map on the right basically shows 5-year estimates of all-cause mortality, and that matches right on to race. So the darker the red, the more the mortality, the worse it is. And our bad outcomes, and every single health indicator maps to look almost exactly like that. Whether it's mortality, diabetes, cancer, pick your cancer, everything maps that way. And that's probably true for most areas. I'm an epidemiologist by training. And so the south side is predominantly African American, the west side is African American and Latinx. And so that maps up onto our issues. So if we take breast cancer, for example, again, this is not only Chicago, but the surrounding counties, and the darker the red, the higher the breast cancer mortality rate. So we looked, I'm going to take breast cancer as the example, and we looked at disparities in Chicago. And this is the mortality rates, aggregate mortality rates for breast cancer between 1981 and 2007. And starting in 1981, the mortality rates were similar. Pretty much. The black women's mortality rates are in the magenta line and the white women in the gray line. But if you look, as we move in time towards 2007, in the 90s, something happened where the mortality rates started to widen. And the mortality rates for white women were significantly lower than black women. And by 2007, black women in Chicago were dying at a rate 62% greater than white women. And so we were like, what the heck's going on? Made the front page of the newspapers. This is a big public health problem, right? And so what we usually do in Chicago is go, oh, New York City's got to be worse. All right, we can't. It's definitely not. But you know, New York City was actually not only better, it was better than the nationwide difference, which was 41%. And there's Chicago, pretty bad. We also did a lot of other maps. This is just one example to kind of get to the bottom of it, right? To get to the bottom of this problem. We got a whole host of stakeholders together. We created a citywide Metropolitan Chicago Breast Cancer Task Force, which include policymakers, many community organizations, national organizations, local, all the institutions. Because mind you, we have 5 major academic institutions and a whole host of millions and millions and millions of dollars of research funding going into those institutions specifically for breast cancer, right? So what is the issue? So these triangles show you hospitals with American College of Surgeons approved cancer programs. And again, this is the community areas of Chicago. Remembering that map, the areas where the highest mortality was, that are shaded in green here, there's no approved American College of Surgeons cancer program, right? Except for that one little triangle on the right lower corner, which is the University of Chicago. There really wasn't anything. There was a mismatch in where those programs were. So where does the problem preside, right? Thinking, implementation, science, right? Design thinking, health equity. Is it inside the woman? Is it outside the woman? Is it about access? Quality of mammography, quality of treatment, quality of the people who are trained to read mammograms, and what are the possible solutions? Do you fix the woman or do you fix the system? So obviously we couldn't, and what is it? Are Chicago African American women different than New York African American women? Fixing the woman makes no sense, right? So we really obviously look to the system. And thinking about it from a social epidemiologic standpoint, the structural elements of the ecology of breast cancer disparities and strategies and how to intervene on them, if you think about it at an individual level, navigation, right, patient navigation, community health workers, promotoras, really speak to that interpersonal issues, like trying to get over the fear and mistrust. And there's a lot of historical fear and mistrust of the medical systems and institutions in our city, so we have to always acknowledge history. When we think about how to solve inequities in health, you have to acknowledge history. And then navigators also help with insufficient health-seeking behaviors, being that bridge and the communication, and being able to translate what the healthcare team is saying to the patient, things like that. Community barriers, right? And then there's health system barriers. So you work on quality improvement, things like that, right? Rapid cycle process improvement strategies, quality care strategies, and implementation science work. And then advocacy and policy is absolutely important as well. So, we know there's a communication challenge, right? This is the $50 million question. If we could package the answer to this equation, we'd get a Nobel Prize. Amount of information, timing of information to get the desired outcome. We just don't know it yet. We did a lot of qualitative work on the ground. We followed women around all the area clinics and mammography centers from the time they came in the door to the time they left. And we documented systems issues, every single process that went into those clinics, and we fed it back into the clinics themselves to help them improve quality. So that's one of the things that we did. Here's a quote from a patient. The quality of care you get from a public health clinic is not going to be the same quality of care you get from a private physician. You can walk into the Board of Health or the county clinic, and it's a completely different atmosphere than the Northwestern Lynn Sage Breast Cancer Center, where you've got nice lights, you've got TV, soft jazz in the background, coffee and snacks, and a can I help you as soon as you walk in the door attitude. They're going to take care of you at Northwestern. And if you go to the Board of Health or the county clinic, there are 30 people all at the same time, and you got to sit there and wait. And this was a comment that basically summarized the entire, all of the interviews that we did and the themes in a nutshell. So even when someone like you or myself goes through an issue with their health, it is extraordinarily complex, right? And then you add all those other social factors and determinants of health and literacy and all these other issues on top of that, and it makes it even more complex, right? So it's just starting at a screen. All of us in this room hopefully have had some kind of screen for some kind of thing. And getting through, if there's an abnormal result, becomes really complicated. So if you just take your own experience or your loved one or family member's experience or helping them through, and then add a ton more barriers on top of that, it's like, whoa, how do we get somebody through this process? The other thing is that when we're delivering healthcare, the patient view is that, oh my gosh, especially in cancer, I have to go to the primary care doctor, and I got to go to the radiologist, I got to go to the breast surgeon, I have to go to the plastic surgeon, the medical oncologist, the nurse practitioners, the social workers. I mean, it just goes down, the pharmacists, everybody, the whole team. And they want to see us all together as one. But as we were doing some of this work to try to bring them all together as one, each of those team members, healthcare team members, would say, oh, that's not my stuff. That's theirs. That's social work's issue. That's the surgeon's issue, not the oncologist's issue. That's the primary care doctor's issue, not ours. And when we tried to get them all onto a Gantt chart or a process of the sequences of care, because I work with systems engineers that help me to develop the sequences of care that I'm about to show you, trying to get all of the team members to agree to be on the same piece of paper in a sequence of care and a team approach was quite challenging. But then once they start using it, so this is a sequence of care, we call it the 4R, the right care at the right time for the right patient, right? This is for breast cancer. Basically, we use the concept of a project plan from systems engineering and a Gantt chart, and we help the patient and their caregiver and the healthcare team visualize the entire care plan on one piece of paper. This is not electronic at this moment because we're still testing it across multiple, both primary care clinics and tertiary care centers. So it's important to bridge both, right? Because often what happens is the patient becomes something like a football, where the diagnosis of cancer, for example, happens in the emergency department or in the primary care clinic, and then the primary care clinic's like, okay, you've got cancer, you're going to Northwestern, or you're going to the University of Chicago, and done. Okay, they're gonna get their care over at the tertiary care center, but what happens about the rest of their comorbidities? What happens when they come back to the primary care home? And that's what we're working on now, is how can we make this care plan inclusive of not only primary care and helping them transition back into the primary care medical home, and to help the primary care providers be more cognizant of that connectivity, so creating more the bridge as opposed to the football pass. We're also doing it in different contexts, different types of healthcare centers. So ones that are, so Howard Brown clinics are very focused on LGBT population, so patients, for example, with HIV plus cancer, things like that. So we're tweaking it, again, implementation science, tweaking it and seeing how it works for different populations and different clinic sites. On the back of that piece of paper is all the phone numbers. So yes, it's cramped in, it's crowded, but it helps It helps the patient more naturally, and the caregiver and family more naturally see the whole picture, as opposed to, okay, you're going to get this handout from the oncologist, this handout from the primary care provider, this handout from the social worker or list, and this handout from the surgeon, etc. Right? It makes everybody on the same team, right? So really speaking to patient-centeredness and connecting that to community, of course, the context. So back to the map. There was that county back there. So the other type of navigation we do, so that's one type of navigation. The other type of navigation we do is one-to-one, right? Patient navigators, community health workers, promotoras de salud. There was a DuPage County, and that's where we started our patient navigation work, because it was the second largest county in Illinois next to Chicago's Cook County. And the demography of urban centers are that new immigrants and impoverished people and families don't necessarily land in urban centers anymore, right? The prices are high, there's violence, think Chicago, the guns. And so suburbs offer that more safety type feel or perception, better schools, opportunities for jobs. But the problem is most suburbs around urban metropolises are not set up with a public health safety net. And so what we did is create this community engaged project around patient navigation, and really focused it on Spanish-speaking patients across an entire county level. And we were able to show that what the navigators did was mitigate the differences in delay to follow-up. So for all the women that we could get Pap tests and mammography for that had abnormal results, we were able to mitigate the difference in delay. And so we were able to get those women who had lower income, lower health literacy, Spanish speaking only, lower patient activation, and were more distrustful in and resolved with that abnormal result, resolution of that abnormal result, or into cancer treatment and through the first round of treatment in a timely fashion. What we also showed is that the patient navigators were able to create community bonds that no one else were able to do the decade prior, right? We had all this, there are in suburban areas, there's resources and there are many community organizations, but the problem is they're not cohesed, right? Again, thinking about the whole team required to lift the health of one person. Well, they weren't talking to each other, and they weren't connecting to the population together. And so our navigators actually, it was like a secondary intervention of creating the bonds, and now those teams are working better across organizations to help the patients in that community, in that suburb. The other part of implementation science is adaptation, right? So we've been able to take navigation and what we've done in other communities and adapt it for the lower income Chinese communities in Chinatown and Chicago. And we just finished this trial and had good results, and over 770 women were navigated for the first time through mammography and cervical cancer screening. The other thing that implementation science does is it can help set navigation benchmarks. It can help set, using evaluation, it can help you benchmark what a community outreach worker or a community health worker can do. So by studying the implementation of patient navigation at a community level, we were able to document the number of mammograms, for example, patient navigators should navigate within a year. Just kind of setting bet, for example, and the types of outreach activities they can do and the number they can do in a year. So that implementation science side of a hybrid trial design, right? You've got the trial of the thing, and then how are we doing the thing? The how are we doing the thing helps you set the benchmarks to evaluate other how people are doing the things. Right? Does that make sense? You can correct me if I'm wrong, Dr. Karan. So it takes a Karan, sorry. It really does take a village, and it's about modifying architecture. So our task force work and all that work has shown decreasing the disparity. So I can show you at Chicago level that all that work, so 2005, 2007 was where the 62% disparity was. Now these data are only to 2013, but it continues to drop. It is not as dramatic as a drop, but there's still about a 35 to 38% difference in mortality between Black and white women. But all that work at a city-wide level, in addition to having passed, we worked on a few bills that became laws in Illinois State that improved reimbursement rates from Medicare to Medicaid, Medicaid rate to Medicare rate, in exchange for providing quality measure data to a repository that we could monitor. So we had to do all that work to just reduce the disparity between Black and white mortality for breast cancer from 62% to 40% and now in the high 30s. But it takes that much to lift people's health. So other things. We just got another R01 to focus on improving perinatal care, which speaks to the really bad disparity in Black-white maternal mortality in this country. It's one of the big disparities that's actually increasing as opposed to decreasing, and we're the only industrialized country on this planet where our rates in maternal mortality are increasing, and that's egregious and unacceptable. The rates of maternal mortality in places, again, New Jersey is in the top 5, unfortunately, and it parallels places like Iran in their maternal mortality rate. So we got a lot of work to do. So we got an R01 just now it's a hybrid 1 trial. So that means we're testing the thing, which is improving the checklist, the perinatal care, actually routine perinatal care, one-on-one, not group care, one-on-one care, delivery, and see if we can actually improve that, because that's the model of care that most women get. Some women, and I know in New Jersey and Newark, you guys have a big grant for the group prenatal care, which I helped launch when I was at Yale a long time ago. But the individual care is still the model, predominant, and especially in rural communities and in under-resourced communities. So we're trying to improve that with a checklist, and that's a hybrid 1 design, so stay tuned for that. But these are the types of things implementation science approach can impact with community members, and that's also a community engaged project, with community members and community health centers and all the different sectors at the table together, working together. So again, I'm near the end of my talk, but I want to talk a little bit about outside of the box thinking, because that structure and that architecture and that design and that implementation science thinking helps us move forward with many other things that are important to health equity. So another thing that's important to health equity is who you see as a patient, right? And who's giving you that care? And is there bias or not? Is there cultural congruence, or at least cultural receptivity? Some of you call it competency. I don't like that word. I like cultural humility. Is it there? And so having a diverse workforce is really, really important. So some of the other work that my center works on is things like training. So we have a lot of programs. It includes a massive open online course that has transitioned to just being a toolkit of the sorts for places around the world. It's in Chicago Public Schools, it's in community colleges, it's in the area health education centers, AHEC, it's Career 911, your future job in medicine and healthcare. It basically walks you through your career portfolio, building your career portfolio, and talks about healthcare careers and a whole bunch of stuff. It can be used like Netflix or Hulu, where you can look at some videos and not others. And then we have a newly funded T37 Minority Health and Health Disparities training program that trains undergrads all the way through postdocs, 10 per year, who are from underrepresented backgrounds in health equity research of all kinds, from bench to community. We have Chicago Health Equity Research Fellows that brings 20 students into my lab every year from around the city working together as opposed to in silos. So we have community college students working next to Northwestern undergrads and all other undergrads working together, so they break down silos and realize that everybody has an opportunity to learn from each other. And community members are right a part of that program, and they teach our students too, right next to faculty. So the other part of this in implementation science is the leadership that Jeff highlighted. And it's important to break down the way we normally do business. So things like U54s, this is our NCI U54 Chicago Cancer Health Equity Collaborative that started a little over 4 years ago, brings University of Illinois at Chicago, Northeastern Illinois University, which are both minority serving institutions, and with Northwestern's Lurie Cancer Center together to really spawn cancer health equity research, training, education with community partners right at the table, community engagement. So it's like a CTSA of the sort for cancer health equity work. And one last thing, thinking outside of the box, is we partner with Chicago Public Libraries. So I have a couple of National Library of Medicine grants that work with Chicago Public Libraries, because libraries, believe it or not, are the most safe spaces in many places around the country, including Chicago, and librarians are the most trusted professional in the country. Not doctors, not nurses, not teachers, librarians. So if you can take the health education information, because information still is power, and you put it in a safe space and you give a safe person, a trusted person delivering that information, then you have a better chance of improving on the mistrust in clinical trial participation. That was the first grant. And now preventive services delivery and preventive services and just accessing care, the how-to, right? So thinking outside of the box, where can we put our messages, where can we put our information, and where can we build the bridges in places where we haven't built bridges before? That is implementation science, and that is health equity work, and that is how we get the we and not the me and the and story, because it's not business as usual. And thank you very much. I'll take questions. That's an old picture, but it's like one of the few that I can get them all smiling at the same time. It's impossible. 4 kids, especially now they're older, getting them all smiling at the same time is quite a challenge. Yeah, and they're cute that age too. Yeah, that's the other thing. So join me too, and feel free. I know there's probably not much time and y'all are hungry, but feel free to contact me anyway. I have a podcast too, Skinny Trees, if you're interested.
I think I can ask the question without a mic. So I was really struck by your 2 charts. By your 2 charts that in both of them, black women's mortality seemed to stay fairly stable. What created the disparity was the rapid drop in white women's mortality.
Yep.
And so I think, I mean, your navigation program is incredible, but I wonder what were the white women getting over that 30-year period that helped their mortality to drop that the black women weren't? And maybe it's as simple as all those hospitals in their communities and not, but I don't think it's that simple.
Well, it's not that simple. They were getting the message to get screened, right? So they were getting the education. They were trusting enough of the system, and they had access to the system and knowledge to know how to access the system, and ability to access, like transportation, not have to take 3 L's in a bus to get someplace. They can get on an Uber more readily, or a Lyft. I don't want to allege to one or the other, or a taxi. They had childcare abilities. They had flexibility with their job. Because mammography centers, for example, or clinics are usually only open during the day and not at night or on the weekends. So they had those types of things available to them. They also had the benefit of research, because most of the samples at the bench are from white women for breast cancer than any other race or ethnic group. And that is an important part of that, because most of the treatments, and you'll see across multiple cancers, and how we're trying to explore new cancer treatments in that precision medicine, right, have the potential to leave certain minority or racial ethnic groups behind if we don't keep trying to include them at the bench and in these trials. So it's a combination.
Melissa, thank you so much. That was really
Thanks.
great.
Thank you.
Can you tell me what were the biggest barriers in terms of engaging the community that you encountered, and how did you get over them?
Yeah, so again, it's not just me, it's the we. There was a ton of people doing this from a ton of different perspectives. And a lot of it is, if you commit to show up, show up. Don't talk first. Leave that bravado. I mean, I always tease Northwestern Medicine because my office is next door to Neiman Marcus, NM, Northwestern Medicine, Neiman Marcus. And it's the Gold Coast. It's beautiful, right? We have marble ceilings, walls. It's like a palace. And it is, when you're coming from that perspective and that historical exclusion and being exclusive, is really important to have that mindset, and that you sit down and you just listen and you take it, because you hear a whole lot of stuff, and then you act on it and you show, and it's an iterative process. So I think that was part of the hardest thing. What helped is I had been in Chicago since 1990 when I started undergrad, and I had been a community organizer and an advocate before I was an epidemiologist in the Chicago Department of Public Health, before I was a medical student. So I did all those things in Chicago before I became a physician. And I think those things that also helped. But community engagement is so crucial, but for some of us, it's not as natural. Like you have to sit and listen and be a part of that work and acknowledge that it takes a while.
Hi there. Thank you for a great talk.
Thank
I
you.
just wanted to ask about, I've worked with system scientists as well, and one of the things that comes up in the collaboration is the difference in perspective on architectural redesign or systems redesign, and their goal frequently being towards optimization of a system and sort of continuous rapid cycle redesign. And of course that can present some challenges, in particular if you're pursuing research, because redesign is difficult to measure, and treatment exposure can be different as redesign occurs. So I'm just curious in sort of two lights, both in terms of a system that it seemed like you were doing some continuous adaptation in the context of implementation, and then also in terms of the multimodal approach that you took. What were strategies that you specifically used to measure heterogeneity of exposure, or to look at treatment exposure or intervention exposure, as the case may be?
That's a great question. So I guess it depended on the project, but the 4R model, the model we're working on, that piece of paper, we are absolutely using rapid cycle process improvement, and Bruce Rapkin from Einstein in the Bronx, he is helping us with how to methodologically analyze those data, so he's got some good approaches that I can share with you, but he's published in some of this stuff. Rapkin is his last name. He's mostly in the cancer world and HIV world. So I think that it requires a lot of that thinking outside of the box and not constraining us to, when we analyze data, well, this is the way we always analyze these data, or this is the way, or these data don't fit into an analysis framework that is traditional. So just like when we in implementation science ventured towards hybrid designs, again, that was an unknown. How can you test the implementation of something at the same time testing the effectiveness? Right, a hybrid design. So I think we have to be more open to those types of approaches to be able to measure things and improvement. But it also comes down to the end of the day, are you meeting those quality metrics, and what's been the pre and what's the post? And it may not be as fancy and merit a JAMA publication or a New England publication, but science that's worthy of implementing is not all in JAMA and New England. I know they're going to kill me for saying that, but that's the truth, right? It's totally true. I mean, I speak with Howard Bauchner a lot on those podcasts as a USPSTF member, and I sometimes just want to jam it in there, but I also have to be nice about it. So it's not all about JAMA.
Okay, I had two questions. Thank you so much for your talk. It was
Thank
excellent,
you.
something that's dear, dear, dear to my heart.
Thank you.
The first question was, offer on clinical trials. You're doing a lot of work, and I noticed that some of the hospitals in the certain areas, there weren't many. Are those hospitals also trained to tell the disparity sections about clinical trials? Is that something that's offered to them? My second question was on education. Education seems to go with women that are diagnosed. Is anything being done with women before they're diagnosed? Because I loved your picture of the apples, how everybody's on a different level. Sometime in my community, I use the thing as a hole in the ground, and some people are given a shovel to dig their way out. Some people are given a teaspoon. So if
Yes.
everybody can't get on the
Yes.
same level, you're never going to get the same outcome.
Yes,
So my
thank you.
question was clinical trials, one, and the other was education.
Absolutely. So I think we're in various stages of that. So hospitals, there's still a lot more room and opportunity for hospitals, especially on the south side, but not only that, throughout the entire metropolitan area, to be more connected to the major trial centers. And so I believe that the public libraries is one way to do that, to make that connectivity a little more natural. Because, again, just like most people don't go to a clinic as often as like a Walgreens or a CVS or a supermarket, you got to find spaces and places to give the information to the patient. So I think it's got to be, we got to arm patients more with education. So the screening, to answer your part of your second question, which we do, and we're doing through the libraries and through other community organizations, because again, this is not a me thing. This is all these there's a whole lot of organizations that work on cancer screening, for example. Lung cancer screening is a newer one that is getting more attention and attraction and grassroots efforts. But also the hospitals being able to provide that information is really important. But I think we still have a long way with getting some of the more community hospitals on board and moving towards that work. But that's also part of the catchment work. For example, a cancer center support grant needs to support and should support as well. Yes.
Thank you so much for your talk. I wanted to ask, you started out with the disparity rate being very public and a call for action.
Oh,
and
yes.
I've experienced some of those dynamics in the past. And, you know, you also mentioned the maternal and actually infant death rates and the disparities that New Jersey struggles with. My question is, how were you able to successfully convince some of the interested parties, leaders, politicians, the like, who want immediate action and results, with really taking the journey with you on, while it looks like a short amount of time, from their perspective, it took more than 24 hours, and so it was there for a very long period of time, but you got an effective approach for the long term. So how were you able to dance that, whether it was breakdance or swing or whatever you all are doing?
Well, so personally, it's salsa and merengue, but you know, I didn't hear that listed, and I don't know why Shinji didn't make that claim to fame, because he's not bad, and even a little bhangra, right? So, you know, I'm just saying, but now he's going to be really embarrassed. Yes, though that could take hours to talk about, and probably over some beer too. But it's an important, very important question, and you got to celebrate wins very openly and honestly, and you've got to celebrate. And you've got to be super honest about who sucks and what sucks. Just got to speak English, and having that, and then at the same time having the policymakers jazzed up, especially you aldermen. This is Chicago, the Windy City, right? So you got to protect the pots of funds our very powerful aldermen have across each community, and so they're like storming the gates. We got to do something ahora, right? We got to do it now. And so what happened was this work came out not out of a Northwestern or a University of Chicago. It came out of Sinai Urban Health Institute with my mentor and good colleague Steve Whitman, and I was part of the team. But it was very important to have it more of a community people doing the work and us supporting it as supporters, and then connecting it to writing policy bills that became laws that changed the rate. So get the carrot, right? Money. And so the aldermen were eager to force the reps in our assembly, our state assembly, to pass the legislation to make the Medicaid rate improve towards the Medicare reimbursement rate, and then in exchange for quality measured data. And so once you get the money and the data connected, and that creates the transparency, you're done. Then it's about that, it rolls. And then you have to be committed and have enough savvy to keep working with the media, so all types of media, so you have to be comfortable with that. And then the political teams, so the mayor's office and all of that jazz, and the aldermen. And then it's all of that has to work together. So it requires a huge task force. It requires a huge effort. So this was a lot of people. And that's just like the surface of the story. And then there's also the backstory stuff, the beer, wine conversation.
I grew up in Southside in Marco and Harvard.
Yeah.
So one thing that I've noticed is that there's not much buy-in from the larger hospitals in Chicago. So, for example, Lurie Children's doesn't really reach out beyond sort of a little bit west. Yeah, sorry. Just hold it up. So they don't
There it
reach
is.
out. Children's doesn't really reach out further than maybe 10 miles. And the poverty in Chicago now is really moved further south into what might not be, the South Chicago area where I grew up, further south. So I was just wondering, other than sort of Medicare reimbursement, which I listen to a lot at Lurie Children's, about reimbursing for the care, do you have any other thoughts about why they don't form networks with the hospitals down in the South Side, Ingalls, and some of the smaller hospitals like where I grew up?
Why they don't? No, I don't have the answer to that. I think, but the important part of what I think Lurie Children's, for example, missed opportunity is that actually we see at Lurie Children's a majority of patients are Latino or Latinx. And the majority of those parents and those families are actually undocumented. Many of them are, the parents. And they were delivered at Prentice Women's Hospital, a lot delivered by me, and transferred over to the NICUs across the bridge, because our hospitals are connected, and then are cared for there. And it's really important, though, to create those types of networks. And there's still, again, just like I answered in the back, your question about the opportunity, I think there's still a lot more opportunity to create those more supportive networks. I always envision this phone a friend type thing. We have that in HIV perinatal care, for example. So reducing our perinatal transmission of HIV to zero required a phone a friend type approach. So we have phones 24/7. Anyone has a question about HIV and pregnancy, they call us. And we actually answer the phone and answer the question or take the patient into our system regardless. And I think that approach needs to happen for maternal, more OB stuff, but also for other things as well. That phone a friend is a really important approach. So opportunity, Sharon.
Hi, Larry Kleinman. Thank you for this lovely talk. I had
Thank you.
a thought or a question and a comment. The question was, when those mortality, as a pediatrician, I often think in terms of life course.
Of course.
So when I saw the divergence of those curves, one of the questions that came to mind was there a racial difference in who the women who were getting pregnant were, or some aspect of their life experience that might be a part of this that precedes the opportunity for health care and other healthy behaviors? So I'll ask that question, then I'll make my comment.
Yeah, I mean, the answer is yes. I believe we haven't done enough work in bias and cultural incongruence, implicit bias. I think every single person on this planet should take the implicit attitudes test and just know about that, the results of their test. It's free, it's anonymous, you can do it. Just Google IAT or implicit attitudes test through the Harvard website. And it's important to know what your biases are and then how to manage that. But I think that's a start. I think we have a lot more to go in terms of racism research, because it really, or discrimination of any form, because it really does impact care in multiple ways and outcomes.
So the comment I wanted to make is, since the IOM, or now the National Academies of Medicine, considers equity to be one of 6 core attributes of quality, there's been very little work to try to have performance measurement adjusted at the top line for equitable or non-equitable care. That is not just identifying the disparities, but we have such a measure. It was actually developed in part by one of your colleagues from New York, Elizabeth Howell. This is part of an ARC CMS center. We're writing it up right now, but if anybody is interested, if you're interested, I'd be happy to share. We also have measures of availability of high-risk OB care that are unique and different, and of course can't pass the NQF muster because they're far too thoughtful and they don't distinguish good care from bad care. It's better care from less good care. And so, but those are also available, and I just wanted to let you and others in the room know about that.
Yeah, no, there's a lot of work being done on the bundles. So I work a lot with the American Hospital Association and other hospital networks. And yeah, these bundles are really important. The AIMS bundles as an example. Maybe thinking about that again, that's a huge implementation science opportunity, especially when it comes to de-implementing. Because across the board, there's a lot of stuff out there that is not, that should not be done anymore. And you can't just keep adding the evidence-based practice if you haven't actually pulled out the old junk, the old way of doing something completely. And so so that has a lot of implications. So as we train medical students and healthcare professionals of the future and researchers of the future, agility is actually one of the main traits that we really need to train, and people to be agile and people to be able to say, okay, this isn't working. I have to eliminate what I learned in medical school or in residency as an example, or what I had to say for my boards to pass, and I got to learn this. Right? And that's hard to do. It's hard to dump, even and especially in a surgical field. Well, this is the way. I always use Vicryl on the fascia. No, you don't need Vicryl on the fascia, right? What about another one? What about Maxon? What about something else? PDS? What about something else, right? And and what are the circumstances? What's the context, right? So you trying to teach a healthcare professional, or just anyone in general, even a child, how to pivot and be agile and learn, stop doing one thing and do it this way because here's the evidence. That's really hard. And in the implementation science world, and from a DIRH, former studies section chair, there's a lot less de-implementation studies than there are implementation studies. So if you want to help get more grants, de-implementation is actually really important and understudied in everything. And try to get a hospital to de-implement something, or a health system. Vince is shaking his head.
I have a question. Thank you very much for the beautiful presentation.
Thank you.
Enjoy a lot. My question is related to the equality and equity. I think we all know that there are disparities in healthcare in the United States. But to what degree are you talking about, are you thinking that we should be pursuing equity? Should we all get equal pay here, or or what, to what degree is that you thinking that we should be, everyone should be equally accessible, since we don't even have a universal health care here in the United States.
Yeah,
so what are you going to preach?
So that's another conversation over beer and wine or something, or tea or coffee or something. But yeah, and that's like hours-long conversation. It's a great question. I personally believe we're all humans on this planet, and that we should treat each other with the fundamental respect that we all deserve as humans. And from that orientation, yes, I believe to the extent that we can design policies and practices, and this is healthcare delivery, as equitable as possible, not equal, but equitable as possible. Yeah, absolutely. Now, equal pay, yeah, of course. But, that's hopefully another team and other people to achieve that. But we do need to look at all of our practices. So just me, myself, and I and my center, right? Any program we do, and anything we do, we're making sure we're paying people appropriately and equitably. We're making sure we're contracting to subcontracts, even just for catering for events from like student, we have a lot of community colleges I work with, student culinary institutes, things like that. I mean, when I talk about equity, I do it in every single way I possibly can to impact every facet of sector that I touch or that my team touches. And that's really important. And so the other thing I do within my own health system and my medical school and university is push for policies that are more equitable. So for example, our residency program, or our GME now, is no longer using USMLE scores for entrance into residency. We've stopped it this year. And so immediately, all right, I get an email, Melissa, this is going to cause so many more applications to need to be reviewed. And I said, that's a great problem to have. And then I had to follow it up with, I'll help you read some applications, right? Because you got to pitch in, right? But those are the things we have to think about: equity and pathways and that structure. Again, implementation science, design thinking, architecture thinking about how pathways were created in the first place that are causing these disparities, causing these differences in pay, causing these differences in people, some groups being at the table and not others. We got to think about every single way, right, that can cause these problems downstream. So USMLE scores are one of those things that should be trashed. It should be pass-fail. But that's my opinion, and some people will disagree with that. But that's yet one more barrier, right? Does that make sense as an example?
So with that, anybody hear me?
Storm the gates is
that,
my bottom line.
Storm the gates, storm the gates. So I actually want to thank both Dr. Simon and Dr. Horan for really engaging comments this morning. I want to invite you all to chat with us during lunch and to continue this conversation. We're going to break now and then reconvene the panel at 12:30. So that gives everybody time to sort of leisurely get your lunch, come in, chat with the people who are here, find others to be able to talk to. One thing that I would ask, though, is if you see a panelist and they're in front of you in the line, let them all go first, because we get to continue eating while they're talking, but they only have this opportunity. So with that, if you can help me give everybody a round of applause. Thank you.